Okay, so welcome back, Dr. Poh Tze Wei.
Hello, hi, can you hear me?
So I'm very honored to introduce to you all the Vietnamese college, Dr. Poh Tze Wei. She is a scientific market manager of Asia Pacific, Beckman Coulter. I know, and I have Google and learn that you have performed many important publication, and now you lead a very important section in Beckman Coulter. And today, Dr. Paul Tze Wei uh, will present the one of the very common biomarker used in diagnosis and also in monitoring the treatment of sepsis, PCT. So, Dr. Poh Tze Wei.
Thank you, Dr. Koi, for the very kind introduction, and it's good to see you again. Can you all see my slides?
Yeah, we can see very clearly.
And this is the Vietnamese, you can see the Vietnamese agenda, right? Okay, so actually the agenda today, I had planned to give a sepsis overview, but as we had such excellent presentations, excellent speakers giving us a very comprehensive overview of sepsis, I would like to really maybe just jump into the laboratory management of sepsis. So the laboratory of diagnosis of sepsis actually includes, a huge variety of tests, and it ranges from blood cultures, urine, cerebrospinal fluid, all the way to maybe routine laboratory tests for for example, using the complete blood count with white blood cell count. Today we learned about monocyte distribution width from our three speakers, and also some standard biomarker tests like CRP, lactate, as well as pro-inflammatory cytokines, TNF alpha, IL-1 beta, or IL-6. And I think the practice really varies from country to country and even within from hospitals to hospitals in the same country. But today, I would really like to maybe focus a bit more on procalcitonin and also share with you some clinical information on clinical and laboratory analytical information on the performance of our procalcitonin assay called Access PCT. So just a quick recap of what is procalcitonin. Procalcitonin is actually, because it's it's before calcitonin. The etymology of the word pro is it's a peptide precursor of calcitonin. And usually in healthy individuals where there is no bacterial infection or no sepsis going on, PCT or procalcitonin concentrations are very low, approximately 0.1 nanograms per mil. However, very often we see that in patients who are experiencing bacterial infections, there is an increase in the transcription or the expression of the calcitonin gene expression. So with this increase in transcription or expression of calcitonin, we do see a a corresponding increase in procalcitonin levels. And as such, procalcitonin has become a fairly effective biomarker in patients with sepsis, as well as it can aid in differentiating between viral and bacterial sepsis origin. So I know today we've heard a lot about the sensitivity, specificity, and area under the curve, and the abilities of procalcitonin to diagnose sepsis and bacterial infections effectively as compared to, for example, CRP, white blood cell count, or monocyte distribution width. But I think this still doesn't take away the fact that data on PCT has been around for a very long time, I think for the past 20 years. And I think some of the key accepted facts about PCT is that not only is it elevated in patients with sepsis and other clinically significant bacterial infections, it can also help to differentiate between viral and sepsis origin. And this is because we see this increased transcription of the calcitonin gene only in in patients with bacterial infection, but not so much in viral infections. And because of this sensitivity to its sensitivity to bacterial infections. PCT has also been shown to have value in have a prognostic value in monitoring the cause and severity of a sepsis systemic inflammatory response. And just to compare against a very commonly used marker in the laboratory, CRP, you can see that PCT actually rises a lot earlier on in the infection as compared to CRP. And we do know that CRP is a fairly cheap biomarker, but it is elevated in a variety of conditions, not necessarily related to infection or sepsis. In certain inflammatory conditions, we also see a rise in CRP. So this is just some of the clinically established cutoffs that we know for PCT. Below zero point 0.5 nanograms per mil, there is a low risk of severe sepsis or septic shock. And I think this was based on my earlier slide in where we described that in healthy individuals, PCT concentrations are actually below zero point 0.1 nanograms per mil. So I think some of the key clinical cutoffs that we all have to remember are zero point 0.5 and 2, because between zero point 0.5 to 2 nanograms per mil, there's a moderate risk of progression to sepsis or septic shock. And at more than 2 nanograms per mil, patient has a high risk of sepsis and or septic shock. And there are a lot of platforms out there offering PCT. Very often, when we do correlation and concordance studies, these are some of the very important clinical cut points that we need to consider, because these are the numbers that clinicians are using when they are assessing sepsis risk of patients, zero point 0.5 and 2. And we want a good concordance at these cutoff points, so that if you were to move from one platform to another, for example, to maybe improve workflow efficiency in laboratory, you want to make sure that the transition for clinicians is unaffected in this sense. So the concordance at zero point 0.5 and 2 must be very strong when transitioning across platforms. Okay. So what is the clinical use of procalcitonin in sepsis? I think we've all discussed this, and I just maybe want to quickly recap. Procalcitonin can be used in all patients where sepsis is suspected. It can be used, it can be repeated within 6 to 24 hours to aid in differential diagnosis of sepsis. And it can be repeated every 24 hours in patients who are at risk of developing sepsis and organ dysfunction. So coming to our product, our Access PCT assay, the Access PCT assay is actually, quite straightforward. It is a sequential two-step sandwich assay. It's labeled with alkaline phosphatase, and it gives you a rapid access to results with a 20 minutes TTFR, which is time to first results. I want to highlight here that there is no biotin involved in the assay. I think in recent years there's been some noise or some literature out there saying that due to biotin interferences, you may see false results in patients who are on biotin supplements. And I think this may matter for certain countries, more for certain countries. For example, in Korea, where there is high intake of biotin supplements, we do see some of these interferences when there are biotin assays being used for biomarkers. So this is an overview of our assay and assay characteristics. I've already mentioned that the time to first result is 20 minutes. Sample volume is 35 microliters. Sample type is serum and plasma. It has a 6-point calibration curve. Analytical measuring range covers a fairly wide range. It's 0.01 to 100 nanograms per mil. And bear in mind that clinical cutoff points for consideration are at 0.5 and 2 nanograms per mil. Of course, with dilution, you can also measure up to 1,000 nanograms per mil. Open reagent pack stability is 42 days, open calibrator vial stability is 90 days, and calibration curve is more than a month, 42 days. So let's go into a quick look at the Access PCT performance. So we have two columns here. We have the criteria or claims, which are indicated in our IFU, and we also have observed results based on real-life validations and evaluations at some of our early sites who have adopted our Access PCT assay. And what we see is that generally that it is very sensitive and a very precise assay, especially at the low end. You can see that the limit of detection is less than 0.01 in our claims, but in real life, we've observed that the LOD is 0.003 nanograms per mil. And the limit of quantification with a 20% CV in our claims is 0.02 nanograms per mil, but observed results in real life, we've seen it go down as low as 0.003 nanograms per mil. Just a little bit more information on the imprecision claims. We see that the total imprecision for excess PCT is less than 8% CV at more than 0.15 nanograms per mil. And within run imprecision, again, is less than 6% CV at concentrations of 0.15 nanograms per mil. So the subsequent slides, I will quickly just run through some of the imprecision studies that we have on hand. And I think this is important because, when measuring PCT, whether it's for diagnosis or prognostic purposes, you want to make sure that, the CVs are low and the assay has excellent low end precision. So what we see here within run, and between day CVs, the CVs are in general very low. I would say 5% or below. And within lab, total imprecision is less than 8%. And this was on the XS2. And on our DXI, we see a similar pattern of, in general, less than 5% CV, I would say. In terms of reproducibility, the results are also very reproducible within runs, between days, between sites, between lots. So overall, CVs, as you can see here, are also low. And this is for the XS2, and we also see a similar pattern for the DXI. So coming back to the precision profile, I just want to remind you that our limit of quantification at 20% CV is 0.02, less than 0.02, and in real life we've observed 0.003 nanograms per mil. And this was based on a CLSI protocol. So this is just to show you the laboratory precision curves, and that's where our limit of lying, limit of detection, and limit of quantification falls. In terms of linearity and hook effect, we did a study using one high sample, one low sample mix to make 8 sample concentrations across the entire analytical measuring range. And we saw acceptable linearity throughout the analytical measuring range of 0.01 to 100 nanograms per mil. In terms of hook effect, we do not see any high dose hook effect up to 5,000 nanograms per mil. This is looking at platform comparisons, comparing the DXI 800 to XS2, and this is comparing DXI 600 to XS2. So overall, you can see that the correlations across different Beckman-Coulter platforms is strong. When we're looking at cross-reactivity and interference, we do not see significant cross-reactivity, and these are all the compounds that we have tested for interferences. I would also like to highlight here that it is not susceptible to biotin interference, as this assay does not use strep-evidin biotin particle chemistry. It uses alkaline phosphatase format. So I think for patients who may be on long-term biotin supplements, this can matter quite a bit. In terms of traceability, I think that's important because we're all aware of the BRAMS assay, BRAMS PCT assay being one of the first on the market. But currently, really, there is no WHO standardized or internationally recognized reference method or reference material for PCT standardization. The analyte in our calibrators is traceable to our working calibrators, and the traceability process is ISO based. However, we are also very aware that many labs, laboratories are also using the BRAMS PCT assay. So we have done a lot of work to look at concordance and correlation with the BRAMS assay, because that was one of the first, not the first, to actually develop PCT on an automated assay platform. So the subsequent slides, I will share with you some information on our assays, correlation and concordance to BRAMS. So here is the data. So I think overall you can see here that the correlation of XS2 of our PCT assay on XS2 and DXI 800 correlates very well with the VIDAS BRAMS PCT assay. I think correlation coefficient is basically almost 1. And if you look at this is across a variety of PCT concentrations. But if you look at the lower end, where we're concerned with, if you want to look at lower end precision, we look at up to 5 nanograms per mil PCT on the Vidas Brams assay. Again, you can see that there's very strong correlation across across the lower end of the measuring range for PCT. So good correlation at low end between excess PCT and Vidas Brams PCT, whether it is on the Access2 platform or on the DXI platform. And we also see very good correlation at the key clinical cutoff points, which are at zero point 0.5 and 2. So we can see that overall agreement is 95%. In some cases, especially at 2 nanograms per mil, where there's increased risk for progression to sepsis or septic shock, overall agreement is almost at 100%. So I think we can conclude from these studies that our overall agreement with the Vidas Brams PCT assay, there is at least more than 95% overall agreement with the predicate method for accurate assessment of patients for risk of progression to severe sepsis and septic shock. And I think this is very important for a lot of laboratories because the Vidas Brams PCT assay, there's still quite a lot of manual working components, and putting it on an Access PCT platform, with automation can help to reduce the number of manual steps. But at the same time, we want to make sure that when making the switch, the overall agreement, especially at the critical clinical cutoff points, it's very high. And here we show that we have more than 95%, in fact, close to 100% clinical concordance at the 2 nanograms per mil cutoff point. We've also compared agreement at the key clinical cutoff points of zero point 0.5 and 2 nanograms to other platforms that are also using the Brams PCT antibody pair. And looking at the comparison, so I talked about the Vidas Brams PCT assay, but we also compared it to the Architect and Roche Lexis. And you can see that overall correlations are high, whether it's Access2 or DXI 800. Overall correlation stays above 95%, and in some cases it's pretty, except for this one here where we saw about 92% overall agreement. But I think overall we can say that there is a very strong correlation and method concordance to Brams PCT methods, especially at the key clinical cutoff points. So I think I just want to again highlight the significance of 0.5 and 2. At 0.5, there's a low risk of severe sepsis and or septic shock. But as a patient progresses towards 2 nanograms per mil or above, there is a high risk of severe sepsis and or septic shock. And these are just some points to note when using the Access PCT. Just because the concentrations are low and there is a low risk, concentrations of less than 0.5 nanograms per mil does not exclude local or systemic infections in their initial stages. If it's between 0.5 and 2, it should be interpreted with patient's overall clinical signs, symptoms, and medical history. If there is, any concentrations less than 2 nanograms per mil, we do recommend to retest PCT within 6 to 24 hours. And while PCT has been highly correlated with systemic bacterial infection, we do see PCT levels going up in other conditions outside of bacterial infections, which are, could be related to major surgery, trauma, burns, etc. So again, these values really should be interpreted with the overall clinical picture. So this is some of the reference intervals that we have obtained from our internal validation. You can see that the median is 0.025 in a healthy population of 202 volunteers, and this was analyzed at an external site with the Access2 immunoassay system. So I think what we can offer for the Access PCT is really a confidence in results, because we have shown strong correlation and strong concordance at the key clinical cutoff points, not just with the Vidas Brams assay, but also with the Architect and the Lexis Roche platform. And these are all using the Brams PCT antibody pair. But with conversion of the assay onto the Access2 platform, especially if there's a lab that already has the current install base, this can actually help to consolidate overall workflow and reduce turnaround time. I didn't share that discussion. I won't be sharing that discussion in this presentation, but there has been a lot of talk about how procalcitonin may not be available 24/7 because it's not part of a consolidated workflow. So again, having a state-of-art PCT assay on our platform with high sensitivity, low end precision, high concordance to establish methods at key cutoffs can help to consolidate the overall workflow, provide rapid access to results as because it will be part of the overall standard lab workflow from blood draw to automated sample processing and data analysis according to other IVD results. So I think we've talked a lot about how monocyte distribution width is available when patient first presents at the emergency department. PCT may be a later test that is ordered as part of the biomarker panel analysis. But again, if this is all consolidated on single platform, then that could help to enable physicians to obtain more rapid access to patient results for better patient care. So this is, I think this has been discussed before in a different format. And like I mentioned before, for example, patient comes in, he has a complete blood count differential. He may get a basic or comprehensive metabolic panel. And MBW, although it's not indicated here, may be included in this as well. And procalcitonin can be ordered at this point when physician suspects infection. And with a consolidation of all of these tests on the platform, I think that will allow for more effective monitoring and management of patient and initiation of treatment, sepsis treatment within a shorter time. Because I think, like Dr. Koi mentioned earlier, I didn't understand the Vietnamese slides, but I do recall that one slide that said, time matters. So we want to detect and diagnose patients more quickly and treat them earlier. Oh, sorry. I think in summary, the sepsis is a frequent severe high healthcare burden disease, as we've heard today, and the current sepsis definition focus on organ dysfunction in response to infection. Early diagnosis and treatment intervention does reduce sepsis-specific mortality, and this is where really consolidation of a lot of these tests onto one single platform to reduce turnaround time does help. And I think just to share some experience from other laboratories, they try to consolidate, for example, cardiac markers with PCT on one platform so that PCT becomes a stat test and physicians are receive that test, within a very short amount of time, so a short turnaround time, so that they have the information to help diagnose patients earlier. And this is important because, as we know, sepsis is a complex inflammatory syndrome that is challenging for biomarker validation. Having a combination of biomarkers will be required to get optimal benefit to manage sepsis, but having that information back in a short amount of time on a more consolidated workflow will also be very important. So I actually want to share one more slide, and this is actually not translated into Vietnamese, so I apologize, but oh, sorry, it's actually here. So I just want to share that we do have a paper published, the two-center comparison of procalcitonin immunoassays across, I think, a variety of different manufacturer platforms. And the investigators actually made a comment that actually even though the access PCT assay is not based on the BRAM's antibody pair, based on this paper, it's actually more aligned to BRAM's PCT sensitive cryptor than other immunoassays using identical BRAM's anti-PCT monoclonal antibodies. Of course, this is just one study, and we maybe need further information to further validate this claim. But I thought to share this with you because it was really a very extensive study used, where many samples were used, and and the comparisons were made across multiple platforms. So I think with that, I would like to end my talk, and happy to take any questions, or I would pass the presentation back to the chair.
Thank you very much, Dr. Wei, for your very technical lecture. So I do hope that majority of participants are the lab person, lab people, so they can understand me. I don't understand. I just what you generate. Uh, um, so we have some question, but until now there are no questions in the in term of technique. Uh, so only one question that do you know that MDW have been used in having study in children and neonates, especially premature baby or not?
Yeah, we don't have those studies yet. This is only for adults above 18.
Yeah. So one question for me is when they use in their study by Crozer, when they use white blood cell count and MDW for diagnosis, and they use the cutoff. So câu hỏi của bạn một bạn là khi mà mình dùng cái công thức bạch cầu với lại cái MDW đó để chẩn đoán viêm khuôn huyết thì mình dùng cutoff là bao nhiêu? Thì thực sự ra các bạn biết là mỗi cái nghiên cứu nó sẽ có khác nhau một xíu, và các bạn biết chúng ta khi mà chúng ta dùng vẽ ra cái đường cong róc đó thì tùy theo cái điểm, ví dụ vị trí cắt càng thấp, ví dụ như là nó cao thì nó càng thấp, thì lúc đó chúng ta có cái độ nhạy càng cao nhưng mà độ đặc hiệu càng thấp. Càng lên cao thì chúng ta sẽ có ngược lại. Vậy thì thường thì người ta sẽ dùng cái chỉ số nào? Thường thường người ta sẽ dùng chỉ số Uden để người ta cộng lại hoặc là trừ ra, tổng cộng vô cái độ nhạy của độ đặc hiệu cái nào cao nhất, tổng số hai cái đó cao nhất thì lúc đó chúng ta sẽ chọn cái cut off. Còn cái câu hỏi của bạn thì ngay trong cái nghiên cứu mà tôi có trình bày á thì người ta dùng là một cái là 20.5, tức là MDW 20.5, và con số thường chúng ta dùng là 20, nhưng mà trong cái nghiên cứu của Crozer đó thì ông dùng là 20.5 và bạch cầu là 12.2. Thì đó là con số để trả lời cho bạn. Còn thực sự ra chưa có đó chỉ là một cái nghiên cứu, tức là làm sao đó chúng ta kết hợp giữa các bạch cầu và MDW thì cái diện tích dưới đường cong nó sẽ cao lên. Còn trong cái nghiên cứu đó thì 20.5 và 12.2. Một câu hỏi khác là khi mà mình dùng cái MDW tăng hay giảm thì gợi ý nhiễm khuôn huyết, thì như hồi nãy trong cái bài tôi có trình bày rồi, khi mà chúng ta có tình trạng nhiễm khuôn huyết thì nó huy động thậm chí ngay cả như là trong tiểu cầu cũng vậy, hay là hồng cầu hay là bạch cầu mono này, thì khi mà chúng ta càng huy động nhiều, cái lứa tuổi nó sẽ càng khác nhau, cho nên cái thể tích nó sẽ càng khác nhau. Chính vì thể tích nó càng khác nhau cho nên cái thể tích nó sẽ càng có sự sai biệt, do vậy cái độ rộng nó sẽ tăng lên. Và cái chỉ số cái ngưỡng mà thường người ta dùng trong các nghiên cứu đa phần đó là 20. Thì trên 20 thì là cái ngưỡng đó là 20, và trên 20 thì có thiên về nhiễm khuẩn huyết, còn dưới 20 thì không có nhiễm khuẩn huyết. Các bạn có câu hỏi nào không ạ? Hết rồi. Hết rồi phải không em? Có, nhưng mà câu hỏi đó nó quá là đơn giản, là phân biệt với nhiễm khuẩn huyết với sốc nhiễm khuẩn huyết, thì cái này là các bạn phải học trả lời. 8 là có rồi, 8 là có rồi. One question, when the patient suspected sepsis, we have started antibiotics, but then we can perform the MDW, and the NDW is not high. So should we stop antibiotics or not? So do you have any recommendation, comment?
That's a very good question. Actually, to be honest, in our clinical study, as you may know, the patients on antibiotics were excluded from enrollment. But what we have seen is that there are some case studies, and I think Dr. Alba also showed there is some prognostic value. So when patient is getting better, MBW does come down.
Mm.
But I think at this point, to make a claim that you should, stop treatment is probably too early because we don't have that claim yet. What we have is just preliminary information to suggest that there could be a prognostic value of using MPW.
Thì câu hỏi của bạn là khi mà một bệnh nhân nghi ngờ có nhiễm khuẩn huyết và đang nhiễm trùng nhiễm khuẩn huyết, đang dùng kháng sinh theo kinh nghiệm, và sau đó xét nghiệm thấy cái MDW này nó không cao thì mình có ngừng kháng sinh hay không? Thì thực sự ra thì cái việc ngừng kháng sinh nó không phải dựa vào riêng cái MDW. Tôi có hỏi ý của cô á, thì thực sự ra tất cả các nghiên cứu mà đã thực hiện cho đến nay về cái MDW thì người ta loại trừ những bệnh nhân đã dùng kháng sinh rồi. Do vậy chắc chắn là không thể nào từ những nghiên cứu đó mà chúng ta có thể có cái khuyến cáo hoặc là cái bình luận gì về cái việc chúng ta nên ngừng kháng sinh hay không. Tuy nhiên cũng có một số cái quan sát người ta thấy là nếu như mình bệnh nhân có nhiễm khuẩn huyết và khi chúng ta điều trị thì đáp ứng tốt thì cái MDW nó cũng có sự thay đổi, và có thể đó là trong tương lai người ta cũng có thể làm nghiên cứu về cái MDW để theo dõi cái đáp ứng điều trị như thế nào, hoặc là cái tiên lượng nó như thế nào. Còn đến bây giờ á, thì tập trung chủ yếu là vào cái việc là nghiên cứu cái giá trị chẩn đoán nhiễm khuẩn huyết sớm của MDW, chứ không phải chưa nói đến cái việc hướng dẫn điều trị. Hướng dẫn điều trị là cái việc có lẽ là trong tương lai chứ không phải là bây giờ. So one question for you, Dr. Wei. Very happy. Um, does the PCT has any special requirements about sample type, sample quality? I meant duration between blood taking time and assay running time, the sample storage condition, etc.
Okay, thank you for the question. I think in general we accept both serum and plasma tubes. In terms of sample stability, I would say nothing special. So as per normal operations.
Yeah.
Yeah.
Một bạn hỏi là có nói thêm về cái giá trị của xét nghiệm safety fast hay không? Thì không biết là bạn có biết tôi hay không, mà bạn hỏi cái này nó giống như là đang đánh vào nỗi đau. Thì cái đây khoảng 2 năm thì tôi rất là mê cái safety fast này, và cũng đã làm một cái đề tài nghiên cứu cấp sở, và khi làm đã được chấp thuận rồi, bắt đầu nghiên cứu rồi, thì công ty Roche mới nói là cái safety fast này sẽ bị hủy bỏ sau 2 năm. Thì mọi người vẫn vẫn muốn tôi là thôi bây giờ đã đăng ký làm rồi thì cứ làm luôn đi để mình có được cái đề tài cấp sở. Nhưng mà tôi thì nói rằng là nghiên cứu để làm cái gì, trong khi đó mình biết cái xét nghiệm này nó sẽ bị bỏ. Do vậy là cái lý do vì sao mà một cái hãng đó người ta bỏ, bởi vì người ta nghĩ là cái safety fast nó không có tốt, tức là nó không xác định được cái con vi khuẩn này là sống hay là con vi khuẩn này nó chết, bởi vì người ta có thể chỉ sử dụng bên cái PCR thôi nên không biết sống hay là chết. Do vậy nó không có phản ánh cái real time được. Thì người ta đang có người ta ủ mưu một cái loại khác, và tôi hiểu cái concept nó rất là tốt, nhưng mà đó là cái chuyện của hãng, mình không được bộc lộ cái bí mật của họ. Tôi nghĩ là trong tương lai họ sẽ có một cái loại khác để thay thế cho safety fast. Cho nên vì tôi rất là mê cái này nhưng mà không làm, hủy bỏ, cho nên chắc là cũng không có dám bình luận gì về cái giá trị của safety fast, bởi vì nó sẽ sắp được bỏ. So now we have no more question. So and also we have now we is 10 past 5 and it's mean 10 past 6 in Singapore.
Yes.
Okay. You must take care of your family. So I don't think we have more questions. So I would like to conclude the very interesting symposium. And thank you very much for your contribution. I'm very happy to see you again after someday. Maybe
Yes.
in future, when you have a first draft of what we have discussed, we will sit together.
Yes, soon. You'll hear from me soon. Thank you, Dr. Koi.
Okay, thank you very much for joining us and giving a very interesting lecture, even though I don't understand very much.
Thank you, Dr. Koi. You're very
Okay,
kind.
bye. Yeah,
Thank you. Bye-bye.
bye.
Bye-bye.
Vậy thì cảm ơn tất cả các đồng nghiệp. Thì chiều hôm nay chúng ta đã có cái buổi hội thảo rất là tôi nghĩ là rất là hấp dẫn về cái một chủ đề nhiễm khuẩn huyết và chẩn đoán sớm nhiễm khuẩn huyết. Thì trong cái chủ đề ngày hôm nay thì chúng ta đã thấy có 3 cái bài trình bày. Bài thứ nhất là của các đồng nghiệp từ Tây Ban Nha, và bác sĩ Fernando đã trình bày sơ lược cái sự phát triển của các guideline từ sepsis 1 đến sepsis 2, sepsis 3. Và sau đó là bác sĩ Anh đã nói về cái điều trị, và đặc biệt là cái việc sử dụng chỉ số MDW trong cái đời thực, tức là trong cái nghiên cứu của cô ở tại bệnh nhân cấp cứu và bệnh nhân hồi sức. Và tôi thì trình bày sơ qua cho các bạn một số cái giá trị, một số cái xét nghiệm, cái biomarker trong chẩn đoán sớm nhiễm khuẩn huyết, và đặc biệt là tập trung vào cái giá trị của MDW, tức là độ rộng của phân bố thể tích bạch cầu mono. Và cuối cùng là một cái bài thiên về kỹ thuật cái xét nghiệm procalcitonin với những cái yêu cầu và cũng như là những giá trị rất là quan trọng của PCT. Thì hình như là cả MDW và PCT là cũng đều của Minh Tâm, đúng không? MDW chắc chắn là của Beckman Coulter rồi, nhưng mà PCT thì chắc chắn là của Minh Tâm. Một lần nữa xin cảm ơn sự tham gia của tất cả các quý đồng nghiệp. Xin cảm ơn Beckman Coulter và đặc biệt là cảm ơn công ty tập đoàn Minh Tâm đã đồng hành cùng với Bệnh viện Đại học Y Dược trong tổ chức cái buổi hội thảo chiều ngày hôm nay. Xin cảm ơn tất cả mọi người ạ.
Để thay mặt cho công ty trách nhiệm hữu hạn thiết bị Minh Tâm thì sau đây xin mời bà Vũ Thị Thu Hiền sẽ có bó hoa để gửi tặng đến Phó Giáo sư Tiến sĩ Lê Minh Khôi ạ. Cũng cảm